Hi, I'm Professor Ken Thompson. I'm the Director of Radiology and Nuclear Medicine at the Alfred Hospital. Today we're demonstrating a case of a renal carcinoma. This is in a man who had a previous colorectal carcinoma and has had part of his liver resected. He's a 65-year-old male. He has bowel above and around the kidney, and the position of the tumour is such that the bowel would prevent us from using normal devices like RFA or cryoablation. The surgeons had a look at this as a case for a partial nephrectomy, and it was rejected on the basis that it would be difficult because of all the previous surgery. With the Maxıo, we would be using electroporation because of the proximity of the bowel. This is going to require 3 needles to be placed. The way we proceed is we do a CT scan. We transfer the data from the CT scan to the Maxıo robot, and then we program the position of the needles and then use Maxıo to tell us exactly where and how to place the needles and how far in and at what angle. Every radiologist believes they're pretty slick at putting needles into various organs, and I've been doing it for quite a long time, and I think I'm pretty slick, like most of my colleagues. However, when you have to place 3 parallel needles into an organ several centimetres below the skin at a compound angle, it's not quite as easy as you might imagine. The critical thing is to get the first needle in place. With the Robio and the Maxıo, we're able to program the needles so that we can be sure we're where we want to be. In the video you're about to watch, you can see how difficult it can be just using step and shoot fluoroscopy on the CT scanner, or even continuous fluoroscopy, to work out where the needle's going when it's in a compound angle. The reason for that is the needle tip is nowhere near the slice of the skin entry point, and it can be very hard to know exactly where your needle went. Here I am planning the Maxıo procedure on the Maxıo workstation. So once I've selected the needle, I select the target point, and then I drag the needle line back out to the skin and see where's a clear path for the needle. So if it's going through a rib or through a piece of bowel or somewhere I don't want to go, then what I can do is scroll down or up in the CT slices and pick a different skin level to what the target level is on the monitor. Once I've selected the path of that needle, then I confirm it, and you can then scroll around and see how that needle looks relative to the ribs in this particular case. And you can see the first needle is nicely placed and appears to be on target. And then I'm ready for a third needle, and we go on to planning it, and this one's going to be several slices further up. Each slice is a millimetre apart, so we count the slices as we scroll through the images to give us an indication of how far to go. The maximum distance for IRE is approximately 2 centimetres, so that's 20 slices. This particular lesion is only about 2 centimetres in diameter, so we're well within the range of the needles. What we use is a little bush, which is a peel-away plastic piece which is disposable. We place that in the jaws of the device and then close the jaws so it's fixed, and then insert the needle through the little clamping device. And then we repeat the process for the next 2 needles. Once we have all 3 needles in place, we then do another CT scan without contrast so that we can do 2 things. We want to check that the needles are in the right place, and then we want to use the workstation to measure the distance between all of the needles. On the final CT scan, you can see that we've now got a good zone of ablation. This is indicated by areas of gas bubbles and a decrease in the attenuation of the treated area. There's no evidence of pneumothorax. We haven't perforated the bowel. We pull the electrodes out one by one and apply a band-aid. So this case has been quite successful as planned. Maxıo has been a great help, and it's been a very good day for everybody. These patients are usually followed up overnight in the hospital, and then we discharge them the next morning. This particular patient has had no complications. It's unusual to have a hematuria unless we're doing ablation right across the centre of the kidney, and we don't expect any further complications. Today we've shown you how we use Maxıo for really quite a tricky renal ablation case for a carcinoma of the kidney. It's something that we do on a regular basis now. We've probably done over the past year 30 or 40 cases like this using the Maxıo robot. We find it's a great advantage to us, and as you'll see by the final images in this case, this tumour was completely ablated without any evidence of damage to the collecting system, the colon, or actually the kidney itself around the area of the tumour. So it's been a very successful case, but with the Maxıo it's becoming more and more routine. And there are other devices on the market for guidance, but Maxıo is the only one that you actually have freedom to place the needle yourself. I mean, it tells you where you should be placing it, but it doesn't actually drive it in itself.
Oh, the other ones drive it in?
There's one that you drive the little joystick and it puts the needle in for you, and that's a whole different range of complexity that then they say, well, how do you know the robot's going to do what you want it to do? And this is absolutely straightforward and simple. I mean, the engineers that developed this thought, what's the best thing you want? You want a guide. You don't want it to actually do that because you're the doctor who's putting the needle in.
Yeah, so, you need the experienced hand to go.
Yeah, make sure you're not going through ribs or something like that, because you can actually feel the rib on the needle and it's ugly. We're one of the Perfint sites of excellence for use of the Maxıo and Robio guidance devices. Yeah. The Alfred Hospital and my department have had an association with Perfint for quite a few years now. We have a Robio guidance device, and we also have a Maxıo guidance robot. We still use the Robio for simple procedures like simple drainages and sacroiliac joints and various spinal joints. We tend to use the Maxıo for ablations and always use the Maxıo for the electroporation. Our relationship with Perfint has been one where we've been assisting them with software development and giving them feedback from the use of these devices with our procedures, and I think it's been a very beneficial process for both Perfint and for my department. I'm not employed by Perfint, and I don't receive any particular financial benefit personally from Perfint.